I would like to start this by asking veterans who are with us today if you would mind standing up just for 1 minute. Thank you for your service. It's very much appreciated. As was said, the VA and the Veterans Healthcare Administration is one of the largest healthcare organizations in the world. And it's under pressure to get larger and more complex. There are underlying trends in the veterans population that's germane to it and also germane across the healthcare industry. One of the personas is represented here by Byron. Byron's a young Marine just back from deployment in theater in Iraq, where he suffered a traumatic brain injury, and that's manifesting itself as epilepsy in his regular life. Warren is a Vietnam-era veteran. And like all of us who were in that era, he's getting older, right? The average age of veterans now is 63 years old. So they have all of the multiple chronic conditions that you would expect from aging. CHF, COPD, chronic pulmonary obstruction. And then NORA, 10% of the veterans today are women, a little over 2 million, and that's going to grow to 2.5 million by 2020. This is putting tremendous pressure and new demand patterns on the Veterans Healthcare Administration for delivery of services. And they've been asked by a number of people, Congress being the primary instigator of this, to transform themselves in the cycle of one congressional term, basically. Now, the VA cannot do much about politics, nor can many of us anyway, right? So what they've done is to set out and say, we need to change the development cycle, and we need to change it materially. So rather than replace the existing electronic health record, VISTA, Veterans Information Systems Technology Architecture, and oh, by the way, I'm going to stop here for a minute. I want to one-up Marcus on this one. If you look at this in the current state, each one of those data stores is an actual instance of VISTA at a facility. VISTA is written in MUMPS, Massachusetts General Hospital Utility Multi-Programming System. Somebody had to do a real stretch, right, to get a clinical type of acronym out of that. What's interesting, though, about MUMPS is it's an interpretive language where the data stops and starts in a flat file, and the logic stops and starts is really hard to define. So you've got 137 of these instances spread across the VA. Now, what do you think might be one of the biggest barriers to agile transformation of the clinical processes for the VHA? Knowing how to use it. Actually, I want to come back to that. It's an interesting story about that. It's this. We have tightly coupled, beyond coupling in a lot of respects, the data and the work processes and the clinical processes together at each VA facility. And those clinical processes, for all intents and purposes, have really not changed since Florence Nightingale invented the hospital. The idea of rounds and orders and so forth. And the reason for that is hospitals were brought into existence to deal with two economic constraints, intellectual capital and financial capital, and build it. Both of those now, right, are free to move in fundamental ways. So the VA, under the guidance of the Honorable Laverne Council, the CIO at the time, said, we're not going to replace one enterprise application system with another just because we can get it from the commercial sector. What we're going to do is we're going to look at how can we develop and deliver technology that allows us to compose new experiences for our veterans and those who are caring for them. And so that's the digital health platform. It has all the attributes that you've been hearing about all morning, so I don't need to go into those in great detail. But I want to give you a use case within the use case that I think explains why this is so important to move to an API-led connectivity and the platform supporting clinical processes. What you have on the screen is an encounter that's involved in an enrollment. And to be very candid, where it gets off the rails with our veterans is at the beginning. When they begin going through the enrollment process, it's maddening. And then they get lost between the VA office and their VHA facility. Literally. No appointments, they get lost. So what the DHP does to address that is when we bring the data in using open standards in healthcare now, the FHIR standard, if you're familiar with it, Fast Healthcare Interoperability Resources, a RESTful API. We get Byron's data from the DoD system. And by the way, that does not exist for all intents and purposes now at all, right? But then what we do with it is we send it to the EHR of record within the digital health platform. We send a copy to the CRM system, right? Because we really should be about patient engagement. We need to find Byron. He may be homeless. We need to get him in. We need to get that appointment done. But what we also do is we run it through real-time analytics that allows us to take that clinical information and look at what programs, clinical programs Byron might be on. In this case, all the indications from the feature set when it's run through the algorithm says we need to enroll him on the TBI protocol now, right? So this changes instead of 3 months, 6 months, 8 months of time passing for him to become a patient of the VA. He becomes a patient of the VA the minute he enrolls. Then we start tracking him down. That's a very fundamental change in the experience that the veterans have in the DHP. And that is done, and this should look very familiar as well. We defined it through the eyes of MuleSoft and being a strategic partner with us in this idea that we would begin with the experience and we'd build those experiences around a persona. So we had physicians in the VA, the VHA, sit with us for 3 straight days and tell us what they wanted Byron's story to be and how they wanted it to be different in terms of his experience as a returning wounded warrior. We did not start doing anything technical until we had scripted that, right? And then we did the parsing and abstractions to the APIs down through each of the levels. And this is the API that made it possible to enroll Byron in the TBI protocol. And there's a host of others in those. I'll give you some, but I want to do one real quick. Time's short. The way people get epilepsy drugs now is pure trial and error, literally, right? The physician will put you on a drug, see what happens, see if your seizure rates go down. If they don't, they'll go to the next and to the next. And these are world-class neurologists doing this, right? So one of the things that we connected through APIs to the DHP is 15 algorithms that can model all anti-epilepsy drugs on the marketplace using Byron's information out of his clinical record as the feature set to the algorithms to provide guidance back to the physician at the time it's most important, and that's when the physician's working with Byron around the emotional issues associated with getting your seizures under control. to provide guidance that can shorten that to periods of weeks, right? That's all working. Now, the algorithms are going into clinical trials, but the early results are very, very impressive. Now, the other theme that's been up here all morning is velocity, right? We did the first sprint for Byron, the TBI patient, and you can see the numbers up there. 3 working weeks. Well, I won't tell you exactly how many man weeks or person weeks it might have been, but we were working with a lot of very young, very high energy engineers from Georgia Tech, and basically you just keep feeding them pizza and they keep hacking, right? And beer. Well, we had a couple that I couldn't do that for because they were underage, but you know, where they went after work, it's not my problem, right? So, spoken like a parent. So we were able to do this and turn it around, and we actually demonstrated it to Ms. Counsel's entire team, the highest level within the VA OIT, Office of Information Technology. And it's the one time, I've been doing this for 40 years, I was a partner with Accenture, it's the first time I got a standing ovation from a potential client that I might be trying to sell them something to, right? This made a difference in how they understood that they could get through the next 2 years until Congress changes again, right? And then we changed it up and went to Secretary McDonald. And now Dr. Shulkin, who's the secretary, their viewpoint was very, very interesting. They said, by doing these public-private collaborations where we can leverage innovations in the private sector by making them just one API call away from the system of record, we can get back into business of providing high-quality care, the best care possible to the veterans, and we'll let the private sector, in collaboration with us, create the technology on which we deliver that care. Now, as I understand it, Uri's going to help me answer questions.
Hi again, everyone. Thank you. That was really, really interesting. I've been a really big fan and supporter of what's been happening at DHP. And I know that we're running very, very short on time, so I think I only have time for maybe 3 questions.
Sure.
The first one is, the story around Byron and the whole approach you took, starting from a person and working backwards, I think speaks a lot to the approach of and the importance really of APIs and the API-led approach. Maybe speak a couple of minutes on that.
It is what drove us. So we didn't go through the interview the docs, do the requirements, check, and you miss them or half get them and so forth like that. We just let them tell the story, then abstracted out where the information needed to be and where it needed to be. That represented the API. I'm talking to the master on this, right? And went through that process. And then using the agile techniques and methodologies, we wrote, we tested, rewrote and tested and delivered it and showed it to the physicians, and they said, that's what we want, and we did that over the 3 weeks.
Yeah, I think it's so fantastic to see that approach in something that's so impactful, so personal, so human. I think it's a lesson for all of us, and really the power of API-led. I think the other question is really, I'm hopeful that MuleSoft was helpful to you in this. Maybe we can spend a moment about what exactly was that collaboration like?
Right. Now, I'm going to start this as an employee of a state institution. I cannot endorse anybody. But I'm old enough now to say I can't do that. But being independent does not mean I don't have opinions, right? And what MuleSoft was able to do, and I think and most importantly in a lot of respects, was not just deliver the tools that we used in order to create the RAML, as helpful as that was. When Niall Darby's help, our solution architecture that was assigned to us, he brought about this discipline of thinking about the abstraction of the processes that allowed us to decompose it in such a fashion when the time came to recompose it, we were able to do that. And this was mentioned earlier from the stage, and it was in your presentation. We could do that without disrupting anyone on either side of the API we were working with. And that discipline to create that abstraction and stay focused, even though our engineers thought it was way too many APIs, they would rather have hardwired it. That discipline was incredibly important to us.
Yeah, and then maybe that actually leads to the third question of this approach that you did. You know, the magnitude is incredible, the personal importance, but the lessons that you have learned here are actually very broadly applicable. Maybe kind of share, you know, what would you say for people in other industries as well?
I think the hardest thing we had, and I think it's true from everything I've been hearing on the stage today, is this is a cultural shock. It's a cultural reorientation that can be very disorienting, right? That those of us who've grown up as I did over these years in IT, we fought very, very hard for structure and governance and trying to get rid of variability and so forth. And it's very hard to explain to people that this is not a parlor trick, right? This is actually real ways to create application networks that allow us, for example, to be persistent and consistent where it matters. So the TBI protocol, we can deploy across all 137, right? So that every epilepsy patient gets treated the same way clinically. Yeah. Now, if the physician wants to change how that works in terms of the intricacies of the workflow there and the community in which he works in, that's fine. That's an API call. So that's that cultural change, because even the end users, the customers, they have been schooled and trained to think, I'm going to have to send my requirements in, they're going to disappear like socks in the dryer, they might show back up 3 years from now, and by that time the business has changed, and what I need now is totally different. Right. And they can't get their head around.
Yeah, that's a very broad message. You know, maybe I literally just wrap it up with the observation that, you know, I think it's not every day that you see a transformation that can be quite so impactful on literally the lives of so many tens of millions of people. You know, in my own family, we've got, you know, my brother is an oncologist at the VA, my father-in-law was a pharmacist and then a patient at the VA. So it is very personal, but I think the lessons that you're talking about and the fact that, you know, you approached a problem that has been worked on for, I don't know, 40 years probably, in this very different way, but insisted on going in that direction, and it's actually paying off. That's really the big lesson that I think we can all take away. This stuff actually works, and it can be extraordinarily transformative.
And I want to do this real quick. Two things. One is, one of the things we discovered too is we don't have to throw away all of Vista, right? That when we looked at it from a digital assets point of view, obviously the data is the currency in this new economy, right? And the VA has unbelievable data because it's been collecting it for 40 years, right? The only institution that has that kind of longitudinal data anywhere. And so by exposing those data sets in phenotypes around diseases and so forth through APIs, right? That is an incredibly valuable data set. A lot of the lower level system information bus stuff, we don't need to throw that kind of stuff away. It works. Yep. We need to go to the edge, and that's what the POC proved. We can go get algorithms as a service from the cloud for clinical decision support. One last thing, the public APIs too that we're beginning to look at doesn't tell the clinical story like I just said, but it's really important. We've done a lot of work with breast cancer patients, and what we discovered through using these same techniques is that if we can help return control to the woman's life, it makes a better cancer experience. And that doesn't directly impact their care, right? Except if we reduce the anxiety levels around using Google Maps to find public transportation to get to the chemo because they're a single parent. Or we can help find them childcare, or we can help find them financial counseling, which are publicly published APIs. We can change the experience in such a fashion that you are now starting to see even better clinical outcomes because we've taken the stress and anxiety level down. So this idea of leveraging all of the APIs are out there around the experience as a healthcare consumer is a transformative thing.
Couldn't agree more. Thank you so much. I know we're ready for lunch. Thank you. Thank you.